So you guys can guess we're pretty behind, so I'm going to speed through this a little bit.
Is hookah smoke?
No, it's not hookah smoke, so Calvin doesn't care. So I want to talk a couple things about smoke inhalation and then certain sequelae you need to worry about afterwards. So you have a surgical note come in, it's a trauma notification, 5 minutes. Firefighter from a nearby fire comes in with difficulty breathing. He's a little tachycardic, blood pressure's fine. He's a little tachypnic. He's setting 97%. Chiefs, what are the things you guys want to set up? Yeah, it's like, I mean, that's the biggest thing with a lot of these smoke inhalation patients, is the airway can become pretty difficult pretty fast. So, you see facial burns, you see soot in the nose, and then if you look at this last picture right here, this is a picture of vocal cords, and on the left it's like a pretty normal picture that we're used to seeing. On the right is what happens when edema takes over, and this can happen pretty fast. The onset of getting like pretty bad edema after smoke exposure can be within minutes to like an hour. So you see somebody who comes in and they look really bad, they're tachypnic, they have obvious facial burns, you should just, in general, you'd want to intubate pretty quickly. Now, there's some people who are obviously need to be intubated, they're in respiratory distress, they have carbonaceous sputum, any obvious swelling, but then there's some less obvious cases, but people who will likely need intubated, so facial edema, large facial burns. You want to get everything ready for these patients. You want a laryngoscope, you want a glidescope, you want a bougie, you want a Crite kit, make sure you have a scalpel, and get different tube sizes set up, because a lot of times you're not going to be able to pass a regular 7.5, but you may be able to get like a smaller 6.0 tube in these patients. Remember that burn patients in general, they, especially with a large amount of total body surface burns, they get really sick for a number of different reasons. They're much more susceptible to ARDS and ventilator-associated pneumonia. So this isn't like any kind of burn on the face we're going to intubate. You do need to think through the case, but be ready to intubate pretty fast.
Hold on. Sorry, I was wondering whether you're going to say it like that. Sorry to interrupt you for this past thing, but you said remember as if that would be something to consider to avoid intubation because it might go to heart. But even if they go into heart,
no, it's true.
you're getting intubated.
I'm just saying, like, it's not so much any facial burn whatsoever you're going to intubate. You do still need to think about whether you're going to or not. Yeah, and in general, we do tend to intubate these people appropriately, but it is something to think about. Once airway's under control, remember this is a trauma patient. We need to do a full trauma evaluation. And at Jacobi, at least, so at Monty you can just order a co-oximetry. It's just a VBG, and it comes with a carboxyhemoglobin or methemoglobin level. At Jacobi, we actually have to send off 2 VBGs. So make sure you do draw that when they initially do come in. Obviously, don't put an IV through burned skin, and then keep them on oxygen. Keep them on a non-rebreather. And we'll go into the reasons for that in a few minutes. So carbon monoxide poisoning is one of the biggest things we worry about with these patients. So I know nobody really likes the biochemistry involved, but if you look at this graph on the right, you can see that when you have a carboxyhemoglobin level of 0, you have 100% oxygen binding capacity with your hemoglobin. As that percentage goes up, so 20, 40, 60, you can see you flatline how much oxygen your hemoglobin can actually bind. Carbon monoxide is a competitive inhibitor. It binds to the hemoglobin molecule and prevents it from binding to oxygen, and it's much more, it ends up binding, it has a much higher affinity for hemoglobin than oxygen does. So that's the main thing that carbon monoxide poisoning does, is it interferes with peripheral oxygen utilization, and it also decreases your total oxygen, your total body oxygen. So epidemiologically, so fire-related exposure is responsible for most cases of carbon monoxide poisoning, but living here in winter, it gets cold, you also have to remember other reasons somebody may have a non-fire related. So intentional poisoning is one, and that's probably the most common, but then poorly functioning heating symptoms, people who live in their cars and are not in a well-ventilated area, heating devices like kerosene or charcoal, all of this can cause some degree of carbon monoxide poisoning. In terms of your general clinical picture, so some of the initial symptoms are very nonspecific: headache, nausea, dizziness. A lot of these patients are actually misdiagnosed as viral syndrome and sent home, especially in the winter. The things that you really want to worry about, so myocardial injury is not that uncommon in carbon monoxide poisoning. All these patients do need an EKG, and older patients with comorbidities do need serial troponins. And they can also cause ventricular arrhythmias in pretty severe cases. And then in terms of neurologic symptoms, so there's the acute process, the acute altered mental status. So they can come in mildly confused, they can come in a coma, they can have seizures. That's more of an acute process. But there is a delayed neuropsychiatric syndrome that occurs with carbon monoxide poisoning. And this can happen, it usually happens within 20 days of exposure, but can happen up to 6 months after the fact. You see cognitive deficits, personality changes, movement disorders. Obviously, like a lot of this is not so important for us in the acute treatment, but it is something to think about when somebody comes in complaining of these types of symptoms with a maybe carbon monoxide exposure in the past. In terms of diagnosis, so history is really important for us. We don't send off carboxyhemoglobin levels off everybody. Well, at least at Jacobi we don't. But history is really important. You know, in mild cases with vague symptoms, you want to get is there a potential cause of carbon monoxide toxicity that these patients could have? In terms of labs, so you want that carboxyhemoglobin level, it's pretty important. You also want a VBG. Lactate, so severe carbon monoxide poisoning can actually cause a pretty profound lactic acidosis. And then cardiac enzymes. Consider a CT head just to rule out other causes of altered mental status. And then in terms of treatment, before I go on to treatment though, a lot of our patients that we get are actually transfers. We are like one of the hyperbaric centers in New York City. So especially chiefs, when you get this, you'll get a phone call saying you'll have these patients come in. Usually what happens is they come in, they're already intubated, they go to hyperbarics and they come back. The burn ICU just needs to know about them. But usually the management in general, you're not taking care of one-to-one. In terms of treatment, 100% oxygen by non-rebreather or ET tube. So oxygen is required until the carboxyhemoglobin level is less than about 10%. And you should provide supplemental oxygen for a couple hours after that. In terms of hyperbarics, it's a little controversial, unclear whether any real benefit has been shown. Standard practice right now is to use hyperbarics for really severe cases, so really high carboxyhemoglobin levels. Anybody who's syncopized, is altered, is in a coma, had a seizure, these patients all should probably go into hyperbarics. Pregnant patients with a CO level greater than 15%, and the reason for that is that the carbon monoxide has a higher affinity for fetal hemoglobin than maternal hemoglobin, so you actually have a lower threshold of using hyperbarics for them. And hyperbarics may be beneficial in preventing delayed neuropsychiatric syndrome, but again, there isn't really any good data to show that. So associated with that, so I'm sure we've all seen carbon monoxide toxicity. Cyanide toxicity is also something to think about with people who come in after smoke inhalation. So cyanide is a mitochondrial toxin. It basically doesn't let you go through oxidative phosphorylation. Sources of exposure, so fire, industrial exposure, and then iatrogenic, so certain chemotherapies, and then a medication, sodium nitroprusside infusions can also cause cyanide toxicity. It basically just stops letting your cells make ATP and you get cell death. Leads to a lot of really bad neurological and cardiovascular effects. In terms of fire, so there was a study done in 1985. They looked at all these patients who were in an airplane that had a fire problem. 20% of these patients had dangerously elevated CO levels, but 90% had dangerously elevated cyanide levels. So it's something to definitely think about, especially our patients who come in. A lot of the symptoms are pretty similar to carbon monoxide poisoning in terms of CNS. They can be altered, they may seize, they may have a little vertigo. So it's something to think about. In terms of the cardiovascular effects, bradycardia and hypotension, not a whole lot of things can cause that, and then some ventricular dysrhythmias. And these patients can also go into renal failure, they can go into rhabdo, and symptoms begin mildly and then progress pretty rapidly. In terms of general testing, so we do our general workup, send off a Tylenol, aspirin level, get an EKG. In terms of specific tests, so an ABG and a chem, you get severe metabolic acidosis with an elevated anion gap. Lactate's obviously high. Cyanide levels are really more, they don't come back that fast, so we can't really base our treatment on whether a cyanide level is, somebody has cyanide toxicity based on their level. And again, we want to differentiate this between CO poisoning. So if you do have somebody smoke inhalation with 2 or more of the following symptoms, they generally recommend to empirically treat for cyanide poisoning. So carbonaceous material in the oropharynx, neurologic dysfunction, metabolic acidosis, or a lactate greater than 8. If you have any 2 of those, you should just go ahead and empirically treat for cyanide poisoning. In terms of the treatment, there are obviously resuscitation, ABCs. Decontamination is really important, so you want to strip these patients as fast as possible. And then, GI contamination. So it's unclear whether this would really help, but up to date at least recommends 1 dose of activated charcoal in adults I don't know necessarily, there's no real data to support this, and I think most people probably wouldn't do this, but something to think about. The antidote. So cyanide kit is the first line treatment. It's hydroxycobalamin. It directly binds cyanide and it helps excrete it in the urine. In addition to this, you give sodium thiosulfate, which just increases the processing of cyanide and it helps make it into an inactive form. It can cause adverse reddish discoloration. So if you see, a lot of times these patients will come in from other hospitals. They'll have been treated with the cyanide kit. They have a Foley and they have it looks like blood in their urine bag. It's actually just a reddish discoloration from the treatment. The important thing is this interferes with colorimetric testing. So pulse ox, hemoglobin, BUN creatinine, your AST, ALTs, all these values are a little off for a couple of days. So you can't really trust what you see after giving the kit. If you don't have hydroxycobalamin, the second line treatment is called the cyanide antidote kit. It's sodium nitrite and amyl nitrite, which induces methemoglobinemia. You want to avoid this in patients with smoke exposure because it decreases your oxygen binding capacity. So not so useful. If you don't have hydroxycobalamin and you have a smoke exposure patient, you basically just double the dose of sodium thiosulfate. And then methemoglobinemia is not really associated with fires, but I know I've had people who get confused between carboxyhemoglobinemia and methemoglobinemia. Methemoglobinemia is basically the iron and the hemoglobin molecule becomes 3+ charge. So it reduces oxygen carrying capacity. It's caused by local anesthetics, the cyanide kit, any nitrates, antimalarials. It's usually caused by a drug exposure. You get some of the same symptoms: anxiety, headache, weakness, lightheadedness, and you can get myocardial ischemia. Suspect this in hypoxic patients who don't improve with supplemental O2. And you can actually get a methemoglobin level, so this is a little bit easier to diagnose than cyanide toxicity, for instance. Management is methylene blue, especially for symptomatic patients or a methemoglobin level greater than 25%. It's contraindicated in patients with G6PD deficiency. And this can cause serotonin syndrome in patients who are on serotonergic psychiatric medications. And that is all.